I'm Dr. Fakir Raveri, and this is nosocomial pneumonia in adults. The first learning objective is given a patient with hospital-acquired or ventilator-associated pneumonia design appropriate empiric therapy. At this point, you should know that community-acquired pneumonia is relatively less severe type of pneumonia caused by less resistant pathogens such as strep pneumo, H. flu, Moraxella catarrhalis, and atypical organisms. When we look at the ventilator-associated pneumonia, it's relatively a more severe disease with mortality as high as 30%, and is typically caused by more resistant pathogens. So the organisms that you want to target empirically are Staphylococcus aureus, which could include methicillin susceptible Staphylococcus aureus or methicillin resistant Staphylococcus aureus, as well as gram-negatives such as Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter species. And these organisms are usually more likely to be drug resistant. Because VAP is caused by drug resistant organism, it is extremely important to be aware of drug resistant variations. These variations in resistant patterns can occur at country level, so different countries have different patterns. Within regions, so different cities or different parts of a large city may have different patterns, as well as hospitals. Different hospitals can have different patterns of resistance. Even within a single institution or single hospital, different ICUs can have different resistant patterns. And of course, another thing that's important to know is the source of specimen. For example, if we have organisms from the urine versus organisms from the pulmonary specimen, they can have different resistant patterns. And that's why it's recommended that all hospitals regularly generate and disseminate local antibiogram, ideally one that's specific to their ICU populations if possible. And it's recommended that hospitals do this at least once a year. Now, one key recommendation from the guideline is that while we want to empirically cover for Staphylococcus aureus, if based on the local resistant patterns, it's unlikely to be, Staphylococcus aureus that's MRSA, it's probably okay to just cover for MSSA instead of MRSA. Now, in real world, I haven't really seen any physicians that would not cover MRSA in patients with VAP, but the guideline is making a point that if based on resistant patterns are likely to be MRSA, it's probably okay to only target MSSA. And there are some agents that cover Pseudomonas as well as MSSA. So piperacillin, tazobactam, and cefepime, for example, cover Pseudomonas as well as MSSA. And while they do not cover MRSA, if based on local resistant patterns, we think that it's unlikely to have VAP due to MRSA, it will be okay to use them. Now, who exactly needs to receive empiric coverage for MRSA? Generally speaking, both MRSA and Pseudomonas are organisms that originate from the healthcare settings. So patients who have received prior IV antibiotic in the past 3 months or 90 days need to receive one agent that has coverage for MRSA, so typically vancomycin. Also, patients with VAP who are being treated in the ICUs where the prevalence of MRSA is more than 10 to 20%, or if the prevalence of MRSA is not known, these patients need to receive one agent that is active for MRSA. Now, the same is true for Pseudomonas when it comes to IV antibiotic treatment in the past 90 days. Now, with Pseudomonas, it's recommended to use 2 agents that are active against Pseudomonas empirically. Especially in ICUs where when the susceptibility rate of Pseudomonas to the agents that we're using are less than 90%. In other words, the resistance rate is more than 10%. Or if the rate of susceptibility on the antibiogram is not available, or if the patient has a structural lung disease such as cystic fibrosis. So these patients need to receive 2 agents that are active against Pseudomonas empirically until we get susceptibility results back. Now, if we are in a ICU where the susceptibility rate for a specific agent is more than 90%, in other words, the rate of resistance is less than 10%, then a single agent is sufficient. Now, keep in mind that most anti-pseudomonal antibiotics, with the exception of delafloxacin, do not cover MRSA. So when we use two agents that are active against pseudomonas, we typically end up adding a third agent for coverage of MRSA. So typically vancomycin. And the reason the guideline recommends two agents active against pseudomonas for empiric therapy is that in case one of the agents doesn't cover the pseudomonas, the other one should cover it. And this is not for every patient. These are patients that are at risk of having multi-drug resistant pseudomonas. And of course, once a pathogen has been identified and susceptibilities are known, there is no reason to continue combination therapy. Now, your MRSA coverage antibiotics are typically vancomycin and linezolid. It's important to not use daptomycin, so you should avoid daptomycin because it's inactivated by surfactant. Now, alternatively, ceftaroline is also available should the patient be unable to take vancomycin or linezolid. But the evidence is with vancomycin and linezolid. Now, for the two agents that we use for pseudomonas, one should be a beta-lactam, and then a second one should be a non-beta-lactam. So the beta-lactams that we choose are piperacillin, tazobactam, cefepime, ceftazidime, imipenem, meropenem, or aztreonam. And non-beta-lactam would be ciprofloxacin, levofloxacin, amikacin, gentamicin, tobramycin. Now, we also have polymyxins like colistin and polymyxin B that are usually reserved as last line. So let's say if someone has received IV antibiotic in the last 90 days, so let's say somebody received ceftriaxone 2 weeks ago and now they have ventilator-associated pneumonia, we can choose an MRSA active agent like vancomycin plus one agent from beta-lactam that's active against pseudomonas. So we can use piperacillin, tazobactam, for example, and plus a second agent, so ciprofloxacin. So the patient will end up receiving three agents. So ciprofloxacin plus piperacillin, tazobactam plus vancomycin. It is extremely important not to use aminoglycosides as monotherapy. So if you were to use gentamicin, for example, it has to be in combination with one of these beta-lactams. Because there has been, in the studies that we have with aminoglycoside monotherapy, the rate of mortality was higher. Now that we know how to treat ventilator-associated pneumonia, let's take a look at treatment of HAP. So for the most part, we follow the same principles. Majority of evidence is with WAP. So we have fewer studies with hospital acquired pneumonia. So majority of these recommendations are derived from WAP. So I let you, so you can see that, IV antibiotic in the past 90 days is still driving most of these recommendations. And you can see that we use the same antibiotics. So if someone has HAP and is not at risk for mortality and no risk factors for MRSA, they can receive a single one of these agents. So these agents will cover pseudomonas as well as MSSA. Whereas if someone is at risk for MRSA, but not at risk for mortality, they can receive one of these agents for pseudomonas, plus either vancomycin or linezolid to cover for MRSA. And of course, if someone is at high risk for mortality, then that patient should receive two agents for pseudomonas plus one agent for vancomycin. So one of the beta-lactams plus one of the non-beta-lactams active against pseudomonas plus an agent for MRSA. We designed appropriate empiric therapy for HAP and VAP. Now, given microbiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of like the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out, more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Here's a pyramid to help us compare broad and narrow spectrum of activity of antibiotics. So the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are on the pyramid, the broader the spectrum of activity. Now I have created a tiering system, so tier 1, 2, 3, 4, 5, 6 doesn't really exist. I just created this to help us understand and compare different antibiotics when it comes to broad versus narrow. So in tier 1, I would place cefazolin, which is a first generation cephalosporin, and trimsulfa and amoxicillin. And that's because when it comes to gram-negative spectrum of activity, these agents have limited activity, limited to protease, E. coli, and Klebsiella species. Now, these organisms can still develop resistance to this, but in general, the activity of these agents are limited to wild type P, E, and K. Now, in tier 2, I would place drugs like ceftriaxone, which is a third generation cephalosporin, and ampicillin sulbactam, which has expanded activity when compared to amoxicillin. And in addition to protease, E. coli, and Klebsiella, these agents are also more likely to cover Haemophilus and Neisseria species. Now in tier 3, I will place ertapenem and gentamicin. Ertapenem is the only carbapenem that does not have activity against Pseudomonas, so therefore it is in tier 3 because these agents do not have activity against Pseudomonas. Now, as of 2023, gentamicin is no longer considered active against Pseudomonas, and that is based to updated review of its PK/PD characteristics. So with the safe doses that we use in patients and with the current MIC in Pseudomonas species, gentamicin is not likely to cover Pseudomonas. So for that reason, it has been placed in tier 3, and these agents do not have activity against Pseudomonas, but they are active against ESBL, so that gives them the advantage over tier 2. So if you have Enterobacterales that are producing ESBL, they will essentially be resistant to the drugs beta-lactams in tier 1 and 2. So ertapenem will be drug of choice for ESBL producing Enterobacterales for severe infections such as bacteremia. And gentamicin, of course, is not affected by ESBL since it's an aminoglycoside. And both of these agents also have extended activity against more gram-negative organisms. So Citrobacter, Providentia, Enterobacter, and Serratia. And they do not have activity against Acinetobacter. Now, when it comes to tier 4, this is when we really start to define broad spectrum because of activity against Pseudomonas. So essentially, this is where most experts would agree, where we draw the line between broad and narrow, because Pseudomonas species can develop resistance relatively easier compared to other organisms. So if you are not suspecting Pseudomonas when you're treating an infection empirically, we shouldn't use an agent that's active against Pseudomonas when we have multiple options. So this is literally the beginning of broad spectrum, and these are drugs that are pretty much active against wild type Pseudomonas aeruginosa. So ciprofloxacin, levofloxacin, tobramycin, cefepime, ceftazidime, and piperacillin tazobactam are the most common ones. And I say wild type because, again, Pseudomonas can develop resistance to these agents, but wild type essentially, where these agents will have intrinsic activity against Pseudomonas. And that's why we have a tier 5. These are agents such as the rest of carbapenems. So remember, ertapenem doesn't have activity against Pseudomonas, but the rest of carbapenems do. And also ceftolozane tazobactam. Ceftolozane tazobactam was specifically designed to be having potent activity against multi-drug resistant Pseudomonas. So when Pseudomonas is resistant to drugs in tier 4, that's when these drugs come in. So, we don't really want to use these for all Pseudomonas. We really want to reserve them for when Pseudomonas turns into multi-drug resistant Pseudomonas. So for that reason, these are typically reserved or restricted in hospitals, and they will require approval for use just to make sure that the ID or antimicrobial stewardship team can get a second look and make sure that their use is appropriate, because the more we use these agents, the more likely that we will lose them to resistance. So we really want to use them judiciously. And then tier 6, they are still active against multi-resistant Pseudomonas, but in addition, they also have activity against carbapenem-resistant Enterobacterales. So some Enterobacterales, of course, can develop ESBL, but the smaller portion of them can also develop resistance to carbapenems. So if, we have E. coli resistant to meropenem, for example, that's when we want to go to tier 6. So these are really reserved for when we have these difficult to treat organisms. So cefiderocol, ceftazidime, avibactam, and some of these carbapenems combined with beta-lactamase inhibitors. So meropenem, vaborbactam, imipenem, relibactam, and also some other classes. So polymyxins, so polymyxin B and colistin, as well as plazomycin, which is an aminoglycoside, the most recent aminoglycoside, has good activity against these agents. They also have a tier 6B because there are agents that are active against CRE and ESBL, but they actually do not have activity against Pseudomonas. So there are actually a hole in tier 6B, but still these are pretty broad, even though they don't have activity against Pseudomonas, because they are active against CRE. So we really want to reserve these for when we don't have other agents available, because when we get infections due to CRE, we really have limited options. And by the time we get to CRE, it's really easy for these organisms to be resistant to multiple classes of antibiotics. So tigecycline, eravacycline, and amikacin, these are they may have activity against CRE, but they don't have activity against Pseudomonas. So amikacin, just like gentamicin, as of 2023, is no longer considered active against amikacin for systemic infections based on its updated review of PK/PD characteristics. The only time that it will be okay to use amikacin for Pseudomonas is if it's in urinary tract infections, and that is because a high concentration of amikacin can be achieved in the urine, and that can meet the PK/PD parameters. But outside of the urine, pretty much based on current circulating organisms, MIC, amikacin is no longer considered active against Pseudomonas for invasive infections. One thing I want to mention about Acinetobacter. Acinetobacter is also an organism that can easily develop resistance to multiple classes of antibiotics. So I mentioned that tier 3 doesn't have activity against Acinetobacter. Now in tier 4, it is depending on the agent, it may or may not have activity against Acinetobacter. And even at tier 5 and 6, even though I have A here in case for Acinetobacter, you really need to check for susceptibility, because Acinetobacter may or may not be resistant to these agents, because again, it's really easy for Acinetobacter to develop resistance to multiple classes of antibiotics. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like vancomycin or linezolid for MRSA, and once the culture and susceptibility results come back, and if it is MRSA, then we continue vancomycin, and then you can discontinue the antibiotics for pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue vancomycin and start the patient on oxacillin or nafcillin or cefazolin, because these are tier 1, these are tier 1 or antibiotics, and you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lungs. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibiotics to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have an ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than piperacillin and tazobactam because it reduces mortality. So my recommendation is to also use carbapenems for pneumonia. But basically we have limited data when it comes to pneumonia with ESBLs. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. Now let's evaluate a patient's clinical stability to determine if antibiotic therapy can be switched from IV to PO. Now, IDSA guidelines for community-acquired pneumonia gives us some guidance for switching patients from IV to PO. Now, keep in mind that community-acquired pneumonia can be treated as outpatient in moderate or less severe patients, whereas in hospital patients, the patient will receive IV antibiotics. So based on IDSA, patients who are hemodynamically stable and clinically improving can be switched from IV to BO as long as they are able to tolerate oral therapy. Another thing to consider is to make sure that the GI tract is also functional. And we can apply some of these principles to patients with nosocomial pneumonia. Now, the reason we want to switch patients from IV to PO as soon as possible, when they can tolerate it, is, first of all, to make sure that we don't introduce any, line infections, as well as getting patients ready to be discharged. However, keep in mind that the guidelines do say that inpatient observation while receiving oral therapy is not necessary. So if the patient is ready to be discharged from the hospital and they're on IV antibiotics, and it's okay to discharge them and send them home with oral antibiotic. It's not necessarily to keep them one extra day to make sure that they tolerate the oral antibiotics. Now, there was a systematic review published in JAMA in 2016 that looked at the evidence for, criteria helping transition patients from IV to PO. So basically, absence of mental confusion, ability to take oral medications, absence of fever, hemodynamic stability, which is defined as heart rate less than 100, and of course, systolic blood pressure greater than 90. This is without using pressors. So, without using norepinephrine, the blood pressure should be greater than 90. Another criteria is respiratory rate lower than 25 and oxygen saturation higher than 90%. And of course, we have to make sure that the patient is clinically improving before we change from IV to PO. And sometimes the patient may not be improving, and there could be different reasons for it. One reason, of course, could be that we have identified the correct organism, or empirically we are targeting the right organism, but we use the inappropriate antibiotic, or we were using the wrong dose. So it's important to, target the right organisms, use the right antibiotics, and also use the right dose. So, we have to make sure that the dosing is appropriate based on body weight, based on renal function, based on hepatic function, and based on drug disease, and drug-food interaction. So as pharmacists, we have to take all of those considerations to make sure that the patient is receiving the right dose. And along with the dose also goes the right frequency. The frequency is also important. Sometimes, the organisms can develop resistance while on treatment. So it's, another thing to consider. If the patient is on the right drug and on the right dose, you may want to question, whether the organism developed resistance while the patient was on the antibiotics. So sometimes we may send another culture just to make sure that the organism is still susceptible to the antibiotics we're using. I talked about the wrong dose. Sometimes the patient may miss a dose. So let's say the nurse comes to administer the antibiotic and the patient is not available. So whether the patient was sent for imaging or the patient, was not available for any reason, that's important to consider, to talk to our nurse colleagues to make sure that the antibiotics were actually administered. Another thing is to make sure that the antibiotics are actually getting to the site of infection. So sometimes, if the organism is in a specific area where antibiotics cannot get, source control becomes really important. So empyema, for example, is an example, when we actually need to make sure we have source control because antibiotics may not be able to get there. So it's important to actually, drain the site of infection. In the case of pneumonia, sometimes the patient may still have like shortness of breath and not seem like they're getting better, and could be due to other reasons that has nothing to do with pneumonia. And of course, we have to target the right organism and use the right empiric therapy to target those organisms. And also we should think of non-infectious causes. If the patient has fever due to, either a clot or cancer, non-infectious causes of fever. Sometimes you may have drug-induced fever. So, beta-lactams, for example, occasionally cause drug fever. And lastly, presence of an unrecognized concurrent infection. So, if you're trying to target pneumonia and suddenly the patient has, bacteremia that led to endocarditis, that could be something that's, could be the reason why the patient is not doing well. And that's important to consider. Given a patient with HAP and VAP, we design appropriate empiric therapy, and given microbiological results, we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated a patient's clinical stability to determine if antibiotic could be switched from IV to PO. Now, let's recommend an appropriate duration of therapy for HAP or VAP. Now, prior to the 2016 IDSA guideline for HAP and VAP, it was usually the question of whether we should treat for 1 or 2 weeks when it comes to, VAP and HAP patients. And it was primarily due to the NUME study, which was published in JAMA in 2003, which looked at 8 days of treatment versus 15 days of treatment. And what they found was that there was actually no difference in mortality between the two groups, whether the patient received 8 days of treatment or 15 days of treatment. However, when they did subgroup analysis, in the group of patients who had VAP due to non-lactose fermenting organisms such as Pseudomonas and Acinetobacter, there was increased recurrent infection in the group of patients who received 8 days of treatment. And because of that, we started to treat patients who had VAP due to Pseudomonas or Acinetobacter for 14 days. Now, things started to heat up when a Cochrane review in 2015 compared short-term therapy to long-term therapy in patients with HAP and VAP, and found that in a group of patients who actually got short course of antibiotics for, let's say, 7 or 8 days, there was actually increased 28-day antibiotic-free days and reduced recurrent VAP due to multi-drug resistant pathogen. In other words, patients who had longer duration of therapy, they actually had more multi-drug resistant pathogens. In addition, there was no difference in mortality, recurrent pneumonia, treatment failure, or hospital length of stay when you compare the two groups. And they did still find that in group of patients who had Pseudomonas Acinetobacter, short course of antibiotics were associated with recurrent infection, but no other differences. So while these patients had the recurrent infection, those recurrent infections were less likely to be due to multi-drug resistant pathogens. So they were easy to treat. Whereas patients who had longer duration of treatment, while they were less likely to have recurrent infections, those recurrent infections were more likely to be multi-drug resistant. There was also a study published in Chest that showed that short course regimen compared to long course therapy was not associated with any difference in mortality, recurrent pneumonia, ventilator-free days, or duration of mechanical ventilation, or length of ICU. So what happened in 2016 when the IDSA guideline came out is that the panel actually did their own systematic review and meta-analysis, and they found that the specific subpopulation with VAP2 to non-glucose fermenting gram-negative organism was analyzed, and no difference was observed for pneumonia recurrence. So here's what the IDSA guideline recommends for length of therapy of VAP. They actually recommend a 7-day course of antimicrobial therapy rather than a longer duration. However, this recommendation is not to replace clinical judgment. So there may be situations in which a shorter or longer duration of antibiotic may be indicated, depending on whether the patient is clinically improving or deteriorating based on radiologic and laboratory parameters. But for most patients, 7 days of antibiotics is likely sufficient. And we can extrapolate from the VAP evidence and make basically the same recommendation for patients with HAP. So also for HAP, the guideline recommends 7-day course of antimicrobial therapy, but this is not to replace clinical judgment. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated patients' clinical stability to switch from IV to PO and recommended appropriate duration of therapy for HAP and VAP. Now let's develop a patient-specific plan for prevention of pneumonia. When it comes to the prevention of pneumonia, the older 2007 IDSA guidelines has several recommendations. Of course, influenza can lead to secondary bacterial pneumonia, so influenza vaccine is recommended, as well as pneumococcal vaccine, which I will discuss shortly. Now, for patients who are hospitalized, vaccination can actually be performed at discharge prior to patients going home, and of course, it can also happen in the outpatient setting. Smoking is a risk factor for pneumonia, so smoking cessation is very important in preventing community-acquired pneumonia. And those who continue to smoke, influenza and pneumococcal vaccination is really important for them. And of course, respiratory hygiene, including washing hands, is really important in preventing spread of germs. The new 2019 IDSA guidelines did not make any new recommendations for prevention of pneumonia. Before we talk about pneumococcal vaccine, it's important to distinguish between pneumococcal disease and meningococcal disease. When we say meningococcal disease, we are talking about meningococcal meningitis specifically, and this is caused by the organism Neisseria meningitidis, which is a gram-negative coccus. Now, there are 12 serogroups, so you will see this in the meningococcal vaccine, and there are different vaccines. For example, the MenACWY has 4 serogroups here, whereas MenB only has the B. Now, when we talk about pneumococcal disease, there are 2 diseases that this may be referring to. So pneumococcal meningitis and also pneumococcal pneumonia. And this is basically caused by Streptococcus pneumoniae, which is a gram-positive coccus. And there are 91 different serotypes. Now we have 2 different pneumococcal vaccines. We have the Pneumovax 23 and we have Prevnar 13, which I will explain shortly. Now it's important to distinguish between these two because there is some misconception out there. When we talk about meningococcal disease, people may refer to this as meningitis vaccine. So it is true that by taking meningococcal vaccine, you will basically prevent meningitis due to Neisseria meningitidis. And people may refer to pneumococcal vaccine as pneumonia vaccine. This is where the misconception comes in because Streptococcus pneumonia can cause pneumonia, but it can also cause meningitis. So by giving patients pneumococcal vaccine, not only are we trying to prevent pneumonia, but also we are trying to prevent meningitis. In fact, Streptococcus pneumoniae can cause several systemic infections, including non-bacteremic, such as pneumonia, and it can also cause bacteremia, which can also lead to meningitis. So meningitis, you can see a smaller portion of these cases are meningitis, but the fatality rate is much higher in meningitis compared to other diseases caused by Streptococcus pneumonia. So really, in order to prevent meningitis, you need 2 vaccines. You need meningococcal vaccine and you need pneumococcal vaccine. There are currently 4 different pneumococcal vaccine products on the market in the United States. The first one is Pneumovax 23, which is a 23-valent pneumococcal polysaccharide vaccine. And what that means is that it includes 23 serotypes of Streptococcus pneumoniae in this vaccine. It is approved for ages 2 years and older, and it is available as a 1-dose vial, so this needs to be drawn into a syringe, can be administered as a intramuscular or a subcutaneous injection, and all of these products must be stored in a refrigerator. And then, so this is PPSV, the rest of them are PCV, or polysaccharide conjugate vaccine. And the first one is Prevnar 13. So this is a 13 valent, and it has 13 of those serotypes. This is approved for ages 6 weeks of age and older. And all of these PCVs are available as a pre-filled syringe, so they can only be given as an intramuscular injection. Most recently, we had Vaxneuvance and Prevnar 20 approved. So Vaxneuvance is a 15 valent PCV, and Prevnar 20, as the name suggests, is a 20 valent PCV. Of note, when both of these came to the market, they were initially approved for ages 18 years or older. Most recently, Vaxneuvance got approval for ages 6 weeks and older. And I anticipate in the next few months, Prevnar 20 will also get approval from the FDA for 6 weeks of age and older, but currently it's only available for adults 18 years or older. Let's take a look at differences between the two main different types of pneumococcal vaccines, pneumococcal polysaccharide vaccine and pneumococcal conjugate vaccine. There are different modalities of vaccines. So polysaccharide vaccines are processed as non-T lymphocyte dependent immunogens, but not immunogenic in children younger than 2 years of age. So that makes it a problem. So that's why pneumococcal polysaccharide vaccine is only available for ages 2 years and older. It's just ineffective for anyone under the age of 2. Protein vaccines, on the other hand, are processed by T lymphocytes and even in neonates induce antibodies. Because these vaccines essentially use the polysaccharides on the capsule of pneumococcal or Streptococcus pneumoniae, one strategy is to link these polysaccharides to a protein carrier, which can be processed by T lymphocytes, and this results in a more long-lasting protective antibody response, even in the very young age, under the age of 2. So that's essentially what we have done with pneumococcal conjugate vaccine. So, and because in general proteins are larger than polysaccharides, there are fewer of these serotypes that were able to fit into the vaccine. So, the polysaccharide, because these are all pure polysaccharides, there are 23 different serotypes in here. With PCV13, proteins, each one of these serotypes is linked to a protein. So only 13 of them could fit. But this is a much better vaccine because of higher immunogenicity in general, but also in young age, under the age of 2. So from 6 weeks to age 2, this will be very effective. So let's compare the efficacy. So for the pneumococcal polysaccharide vaccine is essentially effective in preventing invasive pneumococcal infection. So when we say invasive, think of meningitis. So essentially infection in the brain. And unfortunately, it does not seem to be effective in preventing pneumonia. So none of the studies that evaluated polysaccharide has not shown efficacy for preventing pneumonia. Whereas PCV, it is very effective in reducing invasive infections like meningitis, but also it has been shown to be effective in preventing non-invasive infections such as pneumonia. So historically, people had to get both of these vaccines, PCV13 first because it's very effective, and then Pneumovax 23 to supplement all those serotypes that are not included in PCV13. However, as technology has advanced, we have been able to include more serotypes in the vaccine. So with the PCV15, which came to the market in, actually both of them came to the market in 2021, we have been able to include more serotypes in the PCV vaccines. So PCV15 has 15 serotypes, and what they have shown is that they have shown non-inferiority when it comes to immunogenicity to PCV13. So all of these 13 serotypes in PCV13 are included in PCV15, and it has 2 additional serotypes. So of course it has been shown to be superior to PCV13 for those two unique serotypes, but also it interestingly had better response for serotype 3, which is also included in PCV13. So PCV15 immunogenically pretty good vaccine. Now these are new, so we don't have clinical data. So is it more effective as far as preventing non-invasive and invasive pneumococcal vaccine? We just don't know yet. Now the same can be said about PCV20. So it has all the 13 serotypes from PCV13, and it has 7 new serotypes in it, and it has been shown to be non-inferior to PCV13 with the 13 that are shared. And also PCV20 is targeting more of those serotypes in PPSV23 in the hopes of eliminating the need for getting PPSV23. And it has been shown to be non-inferior to those 7 serotypes that are also included in PPSV23. So here are the recommendations for receiving the pneumococcal vaccination. So in general, we can think of healthy persons with no risk factors for getting pneumococcal disease, and then of course those who have risk factors, and we'll go over what those risk factors are. So in general, for healthy individual, no risk factor, and this is in individuals who have not received pneumococcal vaccines before, because pneumococcal vaccine is also part of childhood immunization nowadays, but a lot of adults, these childhood immunization was not available at the time they were children. So for the large part, the population has not received childhood immunization for pneumococcal. But as time goes on, more and more children who receive their childhood immunization go on to be adults. So these recommendations change in time. So for those who are pneumococcal vaccine naive and are healthy with no risk factors, essentially prior to age 65, it's not recommended for them to receive pneumococcal vaccine because they are not at risk of being exposed to Streptococcus pneumoniae and develop severe disease. However, once individuals turn 65, they are at risk of developing pneumonia and meningitis and other infections due to Streptococcus pneumoniae. So it is recommended for people age 65 to receive 1 dose of PCV20, or if they want, they can get 1 dose of PCV15 instead. So it doesn't matter which one they get. So both of these are now recommended for these individuals. Now, however, because there is a gap between PCV15 and 20, it is recommended that if somebody chooses to get PCV15, they should also get a dose of PPSV23 at least 1 year later. So it's important to note that PCV and PPSV vaccines cannot and should not be administered at the same time. There should be a large time gap between them, and that is recommended to be at least 1 year. So here's what the timing looks like. So obviously if somebody gets PCV20, they're done. There is no need for them to get PPSV23 because most of PPSV23 is covered here, and PCV in general is a better vaccine than PPSV. However, if somebody gets PCV15, they will just have to wait 1 year and then get 1 dose of PPSV23, and they are done. Now, what if somebody had already received the PPSV23 and they have not received their PCV yet? So for those individuals, again, it's recommended that as long as it's been at least 1 year after their PPSV23, then they can get either PCV15 or PCV20. It doesn't matter which one they get. They can get PCV20 if they want, and then they're done. So after this, there is no need for another PPSV23. Now, vaccine doses do not need to be repeated if they are given prior to age 65. So for whatever reason, if somebody received these vaccines prior to age 65, there's no need for them to be repeated after 65. And when PCV15 is used in those with history of PPSV23, it need not be followed by another PPSV23. And lastly, for adults who have received PCV13, which is still on the market, but not completed their recommended pneumococcal vaccine series with PPSV23, they do have the choice to get a PCV20 if PPSV23 is not available. Now let's take a look at those with risk factors. So the risk factors, I have broken them into 3 categories. So the first category is they are immunocompetent. These are just comorbidities. And then the second group are still immunocompetent, but they have some conditions that could expose them to Streptococcus pneumoniae entering the brain and develop meningitis. So this is relatively higher risk than the first group. And then the last is immunocompromising conditions. So, things like asplenia, cancer, HIV, transplant, and other things on the list. So for any of these groups, the recommendation is the same. So essentially, this is, because these are high risk, we're not going to wait till they are 65. So as, between the age of 19 to 64, and this is assuming that, they have not received childhood PCV vaccination, assuming childhood immunization was either not available for these individuals or it was available and they chose not to get them. So between the age of 19 to 64, it is recommended for these individuals who have any of these risk factors to receive 1 dose of PCV20, or they can choose to get 1 dose of PCV15. So it doesn't matter which PCV vaccine they get. These are very effective. It's important to prevent invasive and non-invasive pneumococcal infection in these individuals. Now, if they do choose to get PCV15, it is recommended for them to get 1 dose of PPSV23, and it is important to get it at least 1 year apart. Now, this 1 year apart becomes essentially 8 weeks for those higher risk. So if they have just comorbidity in the first group, they have to wait at least 1 year. But in the second group and the third group, because they are so high risk that you may consider to not wait for a year to give the PPSV23, you can shorten it to 8 weeks and give them PPSV23 if they got PCV15 in order to give them full coverage given their high risk conditions. Now, as before, if for whatever reason they had happened to get the PPSV23 first, then you just have to wait 1 year to give them either PCV15 or PCV20, whatever they choose. Once you give this vaccination, they're done. So once they turn 65, if they have received this, there's really no need for them to get another vaccine. Now, if they turn 65 and they had not received this vaccine, so it is recommended 1 dose of PCV. Either 15 or 20, just like before, or if they had previously received PCV 13, they still need to get a PPSV 23, or they can even get PCV 20 once they turn 65. And here's a summary of what I covered in a table format, which I let you pause this video and review.